Well, welcome everybody. We have finally reached the last content lecture of the course, so well done for getting this far. And this one's a rather important one, but there's still a couple of loose ends from the previous lecture on performance management to finish off. Nevertheless, you could press the pause button and just have a look over this recap of the previous lecture and see if there are things there that you would like to go back and check out later. And now I will show the lecture outline for today, and you can see there's quite a bit in it. The first point is the last part of the performance management topic, and then on we're going to talk about policy implementation research. Okay, so at the end of the previous lecture, I talked about gaming as a potential problem associated with performance management, particularly when it is used primarily for accountability purposes. So I gave the example of the gaming that occurred in the implementation of New Zealand's emergency department target in the 2010s. So emergency department staff did things such as falsifying information about when the patient left ED. Another example was clinicians moving emergency department patients to short stay units in order to avoid breaching the 6-hour target. So we saw that gaming was definitely happening, and it happened in all the 4 hospitals that we looked at in our case study research. Now, one thing to say here is that gaming may be more or less of a problem even when it does occur, but our next question is whether or not it can be avoided or minimized, and if so, how? So one way that gaming could be avoided is to simply monitor the implementers more closely. So to have additional staff, if you like, checking up on the ED nurses to make sure, for example, that they're not falsifying the data. Or a second strategy might be to make sure that there wasn't a chance to falsify the data in the first place, but to set up an independent source of data that couldn't be manipulated. Now, we actually had this at the same time as the ED target. There was the child immunisation target, and there was a central register of child immunisation information that was collected independently of providers. So that was a target that couldn't be gamed in that way. So could you do that for the ED target, for example? Now, thirdly, oops, let's get back there. The third strategy is to refine the performance measures themselves. So this could mean developing more sophisticated performance indicators once you've seen that gaming is occurring in order to counteract that gaming. And that's something that Pollitt discusses in his article that is one of your tutorial readings. He suggests that it's important to change performance indicators regularly because the longer they are there, the more likely people will learn how to game them. Now, the thing about each of these 3 strategies is that they do require more resources. They would require more staff, or the creation of new databases, or new policy work to design new performance measures. And the other thing that they have in common is that they all imply that the answer to addressing gaming is to exert more effective control on frontline staff. But there is another way to approach the issue, of course, and that is to try and understand what motivates staff to game in the first place. So in the ED target, we found in our research that DHBs only began to game the target once they had exhausted all other means. So an important cause of ED crowding lies outside EDs, the patients that were placed in short stay units. This was because they were waiting to be admitted to inpatient wards, but there was no bed available there. That's beyond the ED staff's control. So if these are the main reasons why staff engaged in gaming, then exerting more control on them might not be the best approach. If the problem is a systemic one or lies elsewhere about how the hospital is organised, then it's quite unfair to blame the ED staff themselves for not meeting the target. And this flows in nicely to the topic of our lecture. And I'm just going to, which is researching policy implementation. And I'm just going to show you on this slide, you can look at this in your own time, you can see that policy implementation research is another broad approach, an alternative, if you like, to performance management to judging the success of policy implementation. And what that gaming discussion raises, if you like, is the question of whose perspective counts in judging policy success. Now, I'm just going to, So let's just take a step back. The first thing to mention here is that implementation success and failure is not necessarily black and white. As McConnell made clear in his article about policy success, there are lots of grey areas in between success and failure. But before we explore the reasons for success and failure, we need to ask this more basic question: who is it that wants to know about implementation success? So there's really no objective eye in the sky that ultimately judges the success of policy implementation. Instead, there are lots of different audiences that may come to different conclusions about the same policy, but they are starting from different places. Of course, governments and government agencies are interested in the question of programmatic success or failure of the policies that they are responsible for, and opposition parties are also interested, and judgments of policy success and failure are part of the cut and thrust of electoral politics. So governments have an interest in judgments that their policies are successful, just as oppositions have an interest in showing that they are unsuccessful. Now, to this day, the National Party is adamant that the health targets, including the emergency department target we just talked about, that they introduced in government, they are adamant that they were a success. This debate has been in Parliament recently, and Labor and Andrew Little, as Minister for Health, is just as convinced that they failed. And interestingly, both parties have used the research that myself and my colleagues did on ED target implementation to argue their case. So government and opposition, we expect them to take opposing perspectives, but there's more. So for the ED target, what about the perspectives of the clinicians and the managers in hospital emergency departments themselves? Was the policy a success for them? Actually, the answer to that is different, probably depending on whether you ask ED doctors or ED nurses, for example. What about the ED patients themselves, the people that are meant to benefit from the policy? Okay, so these are all important questions. We'll come back to that. But first, let's cover some common reasons that people might give for implementation failure or success. So one reason is that implementation fails because the resources required to implement a policy, to implement it successfully, are underestimated. So government agencies often make policy decisions without providing sufficient resources for implementation. So resources could include having the right workforce available with the necessary skills, as well as being able to put the right amount of money into it. A second possibility is that implementation fails because the policy initiative is based on faulty logic, perhaps, or inadequate theories of cause and effect. And policy might simply be an aspiration, an exercise in pie-in-the-sky wishful thinking, without much of an idea of how it's supposed to be achieved. So when the results don't materialise, we can say, well, it was never going to work, was it? And a final possibility is that the people involved in implementation didn't do what they were supposed to do. Of course, this is part of McConnell's definition or maybe they did what they weren't supposed to do, as we saw in the ED target gaming example. Now, this is where most attention and the biggest debates about implementation have occurred from those involved in researching it systematically. It's the lack of fit or between what governments prioritise and what's important to those involved in implementation. So, when research into policy implementation first became common in the 1970s and 1980s, two competing approaches emerged. These approaches differed according to how researchers answered the question, whose perspective counts? So the first one we've kind of covered already throughout the course, and that's we could call that a top-down approach that takes the perspective that it's the job of governments to make policy decisions, it's their responsibility, and therefore it's reasonable to expect that those policies will be implemented as governments intended. So if policy implementation fails, the remedy is more effective control, more effective understanding of causes and effects, or more effective control over implementers to ensure that they are accountable. That's what we call a top-down approach. But on the other hand, there are those and researchers who took this approach going back to about the early 1980s, started from a different premise that the policy decisions, innovations, and solutions somehow have to make sense to those who are being asked or required or forced to do something different. So this approach was labelled the bottom-up approach. So researchers who adopted this approach argued that the motivation of the whole range of actors involved in implementation need to be considered. Now, I'll give an example where you can see the difference. I remember some research carried out at the School of Population Health a few years ago into the implementation of a screening tool for postnatal depression in new mothers. And this screening tool was meant to be implemented by midwives. And the research basically found that not much happened because the midwives didn't do this or they didn't do it properly. Now, the midwives, if you talk to the midwives, they would certainly bristle at this. From their perspective, the contract under which they were working was barely sufficient to cover their costs. They weren't being paid extra to do these things. They were already expected to deliver so many things under the contract already. And here's yet another demand, added to an expectation that they screen for family violence, which is added to their workload, and one that they don't think that they have the requisite training for. Now, from a bottom-up perspective, you would say that implementation failed because the people who decided on the policy, perhaps in the Ministry of Health, did not understand the world of midwives as implementers and the conditions that they faced. So this debate mattered a lot because the implications of each approach are absolutely opposed to each other, if you like. So take a moment to absorb this slide, because there are all sorts of connections with other material that we have covered in the course. Okay. So this was a heated debate amongst policy researchers in the 1980s, but the heat went out of it fairly quickly because I guess people on both sides of the debates realised that there were things that they could take and learn from each other, and we can learn some general lessons too. So most sophisticated approaches to judging policy success incorporate elements of both. It is probably sort of counterintuitive to judge policy success without taking into account the objectives, the policy objectives that governments establish. But understanding the possible implications of a policy decision on those affected is also crucially important. So there are two broad categories here, by the way. There are the end users or the target populations. So if you have a policy that's about reducing smoking, then it could be the young people at risk of taking up smoking themselves that are the target. Or we could be talking about women about to give birth if we are trying to, if the policy is about reducing the rate of cesarean sections. And then we have the practitioners, the professionals, and the occupations whose work is affected by policy changes. And often it's this link in the chain that's the most important. So, as with the midwives example, some of the key questions we can ask is, how does a new policy initiative fit with the existing workload and expectations and responsibilities of what was called in the literature street-level bureaucrats? We can call them frontline practitioners. So in health services policy, this link, how organisations and practitioners make sense of new requirements, is the crucial one. How do they interpret a policy initiative? Does it fit with their images of what they are doing and what they should be doing, their professional motivation, their organisational mission, or does it challenge and threaten it? Now, for governments, knowing these things prior to implementation rather than being surprised by them is a good approach. And so that's a very good reason to include and to factor in these sorts of considerations in designing policies in the first place. So this should sound familiar. It should, because we talked about co-design as an important feature of collaborative networking approaches to governance. And remember that a defining feature of new public governance was that implementers need to be involved in the formulation of policy itself. But there are limits to this. For example, what if the whole point of a policy is to stop or prevent frontline workers from doing certain things that are problematic? So, if the intention of a policy is to stop police officers from racially profiling young Māori, then how much do you really want to engage frontline police in the design of that, if it is their behaviour itself that is defined as the problem? That's an interesting question, and I think there is a range of answers to that question, but there are limits, I guess, to the legitimacy of involving implementers in policy decisions. But those are, I guess, relatively rare cases. So we have seen many other examples where bottom-up perspectives and the priorities of those involved in implementation are built into policy design. So I'll give some examples from my own research. I've spent some time in Ontario, the biggest province in Canada, over the past 5 or 6 years, and was involved in researching the implementation of a policy initiative called Health Links. The basic idea of this policy was to encourage a range of service providers, primary care, hospitals, mental health, community-based care, to collaborate in dealing with complex patients with chronic conditions. And the Ontario Ministry of Health provided some seed funding, but it set up what it called a low rules environment in which local services could work out for themselves how best to achieve better coordination of care for these patients. Now, closer to home, I may have mentioned earlier the system level measures approach to assessing health system performance. So it's actually a new public governance approach to performance management. So this sort of thing is starting to happen in many policy areas. So it's where collaboration, networking, and using performance information for learning rather than accountability is part of the policy design itself. So Pushkar and I have been involved in researching the implementation of that policy, and I've been involved with colleagues in Ontario and the Ontario one. So we can tell you a bit about whether this type of policy approach actually works. Is this approach successful? Now, the short answer is that it works sometimes, in some conditions, in some places, and it doesn't in others. Now, both of these examples, there were some health service providers and organisations that really relished and welcomed the opportunity to develop these local collaborations, and they welcomed the low rules approach, and they wanted to collaborate with each other, whereas in other places, the local organisations kept asking for more direction and specifics. Tell us what to do. We don't know what to do. You tell us what you want, they would say to the ministry. So these bottom-up based approaches to policy design work when the implementers want to be involved in design, but they work less well when the implementers themselves are used to a top-down way of working, or they're not interested in collaborating. And that leads us to a nice paradoxical observation. Can you force organisations to work together collaboratively? Okay, there's plenty more to say about that, but I'm going to go on to the last slide now, which is about evaluation. Now, I'm involved in policy implementation research as part of my academic job, but many other people do it and work for companies and organisations that are specifically set up to do this type of work. So what you'll have noticed in the policy implementation assignment is that each of them starts with an evaluation report. What is evaluation? It involves valuing, assessing the merit, significance, and worth of a policy program. In other words, assessing how successful it is. The discipline of evaluation requires a systemic research-based approach, although sometimes universities do it, but most often it's done outside universities. By the way, there is a postgraduate course in our school in evaluation research methods. It's Popple Health 705 if you want to do a Masters of Health Leadership or a Masters of Public Health. It's available in that suite of courses. Now, when you look at the evaluation reports that are the basis of your third assignment, you can look at the reports in light of the questions we've just been talking about. So how do the evaluators define policy success? Whose perspectives are important in judging success and failure? So it's important to remember that many evaluation reports are contracted or commissioned by government agencies responsible for policy implementation. Now, I would say generally these agencies are genuinely interested in understanding success and failure and the grey areas in between, and to use this research for learning. But of course, the government agencies are also often accountable for policy implementation. So this tension between accountability and learning is also lies at the heart of evaluation. More generally, evaluation is a critically important skill set and profession for policy and for the health sector more generally. Evaluators are trained to take into account the wide range of perspectives that we talked about earlier. And so they are skilled in balancing the need to sort of think about policy success in terms of accountability and to think about it in terms of learning. And many students who've been involved or passed through the Bachelor of Health Sciences have gone on to a career in evaluation. So if you're interested in the topics we've talked about today, you might want to have a look at that or explore that as a career option. Okay, that's enough for now. And so on Monday, we will have a live lecture to wrap up the course, bring together the themes, and to talk about the exam. So I will see you all online then. Thank you very much.